Okay, so we've talked about the nature of the problem. Let's talk a little bit now about why it's so complicated. So if we break down the complexity of the problem into two major categories, there are the inter and intrapersonal reasons. I had to actually Google intrapersonal because I couldn't quite remember, but interpersonal is interactions between two people. Intrapersonal is kind of interaction that you have inside yourself, and I have alluded to that a little bit with my own countertransference issues. And then there are the ecological or extrapersonal reasons that are contributing to this problem. So focusing on first the inter and intrapersonal reasons, that is the reasons that come up in the patient-provider dyad that make this such a tough problem to tackle, is number one, patient issues having to do with denial. So we all engage in the defense mechanism of denial to varying degrees throughout our lives. But patients with addiction really have a very robust denial process, so much so that we often speak of people leading a double life, where they have their day job and they seem functional, and then they have this whole separate behavior over here, which they know is there, but they have an amazing ability to compartmentalize it, and in the moment when they're narrating themselves to others, even kind of convince themselves that this over here is not happening. There's also what I call the con, the manipulation that goes on when people who abuse prescription drugs work hard to get them from a provider. And I think it's important to point out that the con is not necessarily malingering. The con is part of the addictive process. So addiction is an incredibly compulsive, obsessional disorder. Patients who are in the throes of severe addiction will do anything that it takes to get their drug of choice. Really almost to an impressive and awesome degree in my experience. Finally, there are the issues that the provider goes through, issues of countertransference having to do with their own addictive issues, their own family members with addiction, or even just the disdain that we might feel vis-a-vis a patient who is destroying themselves and destroying the lives of the people that they care about. There's also the inherent narcissism, a healthy narcissism that we invest in our profession in order to take care of people. But inevitably, we tend to prefer patients who like us and who get better. And patients with addiction don't really like us initially if we suggest that they may have addiction. So we don't really like to go there because that threatens our own competence. Okay, the best definition of denial that I've ever heard was an addict patient of mine who said, denial means don't even know I am lying. And I think that's important just to conceptualize so that, again, in that interpersonal dyad, we can feel taken by these patients. You know, we can have resentment and anger toward them because they lied to us. But if you conceptualize denial as part of the illness of addiction, that pivot allows us to recapture our compassion in caring for these patients. And obviously, if we can recapture our compassion, we can help them. What I'm going to do next is talk a little bit about the different types of cons that I've encountered. And this is by no means a complete list, but I'm going to just put it out there. There's the bully. Everybody knows the bully. That's the person who threatens to sue you if you don't prescribe their pain medications because they're in so much pain. And there are even lawsuits where physicians have been accused of denying patients adequate pain treatment, and they have lost those lawsuits. So that's a real deal. There's the exhibitionist. I don't know if you all have encountered the exhibitionist. This is the person who's writhing on the floor in terrible pain, pulling up their shirt to show you their colostomy bag. It's all very dramatic. Basically, they're on fire in your office, and you've got the fire hose. How could you not be willing to turn on that stream of water and put it out? You're denying them their meds. There's the senator. This is the patient who indulges in the filibuster. They talk the whole entire session, and in that last 30 seconds when you're already running over, they ask for their pain meds. You're in a rush. You've got a big clinic. You just write them in to get them out the door. There's the loser. The loser is the classic, I lost my pills, they got flushed down the toilet, they fell over the edge of the boat when I was fishing. I don't know how many, how many times I've heard that I've lost my pills. There's the weekender, and this is really a fully mastered art for the addict. You call on the weekend when your doctor's not there. You get the cross-covering doctor. The cross-covering doctor can't be bothered with you. They're so busy. Their pager's going off every 5 seconds. You want your 15 of Adderall, here you go, and let somebody else deal with it. There's the country mouse. This is a tricky one. These are the folks who just come with these wide eyes. Oh, I just really want to get off these pain medicines, and I heard but I still have a lot of pain. And I heard there was one oxy. So it seems so innocent. They don't know what they're talking about. That's a classic maneuver. The dynamic duo, they come in with their codependent mother. So not only are they writhing on the ground, but the mom's crying, please help me, please help me. Methadone's the only thing. It's 2 against 1. You're absolutely beat. And finally, this is the trickiest one. This is what I call the twin. This is the patient who is a lot like you, similar background, similar education, maybe even a healthcare provider, maybe even another pain psychologist. Really, really hard. And in my career, I have made the biggest mistakes with patients that I personally identified with in one way or another. Either they had a similar journey in their past, they overcame obstacles in much the way that I overcame obstacles in my own mind, et cetera, et cetera. These are really, really tricky folks. Okay, so if we move now beyond the dyadic or inter and intrapersonal reasons why this is so complex, let's look at the larger systemic reasons. And these, again, are a lot of things that you already know about, but I'm just going to try to categorize them. Huge financial incentives for providers to treat disorders other than addiction. Almost no financial incentives to treat addiction. It was interesting to hear Sean and those of you in the audience talk about how you struggle to get reimbursed to treat chronic pain, but I can say if chronic pain treatment is up here on the reimbursement ladder, addiction is down here. Hopefully with the Affordable Care Act, that will get better. Financial incentives for patients. It cannot be underestimated how much things like workers' compensation and disability play into not only their identity as a patient with a medical disorder, preferably a physical one, not a mental one, how much that plays into all of their patient behaviors and actually puts them at elevated risk to abuse prescription medications based on sheer access. There are also many modern medical narratives that contribute to the problem of prescription drug abuse. One of them that I raise with caution is this idea of pain as the 5th vital sign. And certainly people with pain need to be treated for their pain, but what has happened in about the last 10 years in medicine is that it became such a mandate for physicians to treat pain and treat it aggressively that they were totally ignoring any other issues suggestive of addiction, prescription drug abuse. So that's something that we on the addiction side of things, although we completely acknowledge the importance of all kinds of modalities to treat pain, we want to see a bit of a pendulum swing in terms of also bringing in the addiction aspect. Other modern medical narratives that get in the way of addiction treatment actually is the stages of change. So here's what happens at Stanford emergency room when an alcoholic comes in. The alcoholic comes in intoxicated. They sober them up just enough so they can kind of get out the door. They say to them, do you want to get sober? Do you want treatment for addiction? So they're like barely sober. They're barely, they're weaving along here. Most folks, at that stage of withdrawal, their brains are not their own. They're not coherent. Patient says, no, I'm not interested in that because they're still craving more alcohol, and now we're just using gabapentin, not even Ativan, in withdrawal in the ED. And so they say, okay, you don't want treatment? We're not going to admit you. They walk out the door. In fact, if you look at the data on stages of change, and let me just say with a huge caveat, stages of change is a useful way to conceptualize how people move through behavior change. But there really is no evidence that says that a given stage in the behavior, in the stages of change model, predicts people changing their behavior around substance use. It turns out that sometimes just saying, stop it now, works just as well as motivational interviewing. So I think it's important to, because what's happened basically is that we're saying, well, addiction is one of those things you can't get better unless you want to. There's a lot of truth in that. You can lead a horse to water, but you can't make it drink. Nonetheless, I think we have really erred as healthcare providers on kind of waiting for people to be ready to make change. Somebody just have to say, hit them over the head with a 2x4. You're killing yourself. You know, make a change. Next, there's the Toyotaization of medical care. That's a term that I've coined sort of as my sort of, I don't know, my resistance toward the Toyota Lean movement. I don't know if you guys have that, but in hospitals, it's all about Toyota Lean. So what's happened is they've taken the Toyota, in the Toyota organization, they have this Toyota Lean model, which is how they figure out, they do like a root cause analysis to figure out why are our cars not working. And then they do that, and then they solve the problem. So now that Toyota Lean model has actually been adapted to a huge number of hospital settings. We're all encouraged to do Toyota Lean. And I think what's missing in all that is part of the problem is this kind of assembly line nature of medical care. Patients start here, they go there, they go there. Nobody's taking care of the whole patient. Nobody's really taking responsibility. With this issue of prescription drug abuse, I, on a daily basis, inherit patients on insane medication regimens that I am obliged to continue. Because were I not to continue that, the patient, number one, wouldn't stay in treatment with me, but also might potentially go into some kind of life-threatening withdrawal. So this is kind of this fractured nature of medical care has really made this problem difficult to tackle. There are huge limits on information exchange, especially having to do with addictive disorders. There's something called the 42 CRF, the Code of Federal Regulations, which puts the standard of disclosure even higher than that of HIPAA. So if I'm an addiction treatment specialist and I want to communicate to another provider that my patient is abusing the prescription drugs that person is prescribing them, I need to have written informed consent for every single communication, which makes things tough, and even when you're working within the same medical system. And then there are cultural factors within subpopulations. For example, there's a huge prescription drug abuse problem in Utah. And no one's really looked at that. It's an interesting phenomenon. I have some speculation about what's causing that, but it may well have to do with the fact that there may be a baseline rate of vulnerability to addiction within the Mormon population, like there is in the general population, but because of the Mormon word of wisdom, in which they don't drink alcohol, smoke cigarettes, use caffeine, the prescription drug abuse pathway is sort of like a sanctioned pathway for folks who are vulnerable to addiction. Another huge subpopulation is the veterans population, folks with PTSD, terrible injuries from combat exposure, and then I'll talk about also the enormous economic incentives for veterans to be patients and how that plays into it. So I can't focus on all of these various categories, but I am going to focus on the financial incentives for patients. So I'm going to ask you to indulge me in a bit of a digression on disability and the ways that disability has changed in the last 30 years in this country. There are 3 federally funded disability programs. There's Social Security disability insurance. That's for people who have worked and paid into disability and now are unable to work due to their disability. There's supplemental security income. That's for people who have never paid into the system, who have been chronically unemployed. And then there's veterans disability compensation for our military personnel. It was interesting, in the 1980s, so by the way, as a little side note, addiction used to be a federally qualifying disability. In the 1990s, those laws were changed, and you can no longer be on disability for an addictive disorder. The other thing that happened was in the 1980s, there were changes in disability screening laws, during which objective criteria became less important than subjective criteria. There was also a change in the 1980s, and there was increased earnings inequality and a steady rise in disability payments. And you all probably remember that under Clinton there was welfare reform, so that fewer people had access to a safety net funds just because they were poor, at the same time that there was hugely increased access to safety net forms if you were disabled. And for all of those reasons, the numbers of disability recipients has been steadily rising since the 1970s. In 1957, there were 150,000 non-elderly adults on SSDI. In In 1977, that number was 2.8 million non-elderly adults on SSDI, an incredible, incredible increase. By the way, the largest increases are in mental health and chronic pain disorders. Let's compare the numbers. In 1983, heart disease was the #1 reason for disability. 2003, mental and musculoskeletal disorders are the #1 reason for disability. If we look specifically at the veterans population, in 2013, PTSD was the most common mental health service-connected disability. You probably have heard quotes that 30% of the veterans population now qualifies for PTSD. PTSD constitutes 21% of all VDC benefits dollars, and that's a 150% increase since 1999. If we drill down and look more closely at that, what we find in a very interesting article in the Journal of Public Economics, published 2010, they asked which veterans are most likely to be on disability for PTSD. Guess what? Not those with the most war theater exposure, not those with the most wartime injuries. What was the biggest predictor of being a veteran on a disability for PTSD? Those with the lowest earning potential, lowest previous education level, lowest skill level. The huge increase in the number of people on disability nationally is furthermore not explained by health trends. Population-wide improvements in health measures have improved since 1984. So Autor and Duggan, who've looked closely at this issue, summarize it as follows. Disability programs have come to function like a non-employability insurance program for a subset of beneficiaries, rather than primarily as an insurance program for the medically impaired. Another way to phrase that is that we have essentially medicalized poverty. If you have a chance to read the article by Patricia Webb in the Boston Globe 2010, it's absolutely riveting. It's the story of, and this is an actual picture from the article, of a young mother living in the Roxbury, Massachusetts. She's got 3 boys, and she's having trouble making ends meet, can't pay her bills. So her neighbors come to her and say, why don't you go get your kids on disability for ADHD? She said, my kids don't have ADHD, they're just rambunctious. I'm not going to do that. Time goes on, she really can't pay her bills. She decides to give it a try, goes and sees a doctor. The doctor diagnoses ADHD in all 3 of her boys, and she applies for disability, doesn't get it. Goes to another doctor, gets another signing off on the disability, applies for disability, doesn't get it. Finally, she goes back to the doctor and says, what do I need to do to get disability? You know what, you really need to get your kids on Adderall. Gets her kids Adderall prescriptions, applies for disability, gets disability. And the reason that this is relevant to a discussion of prescription drug abuse is because it really does imply that we've kind of got a societal Munchausen's going on here, a whole subpopulation of people who adopt the patient role in order to pay their bills, and in that process, not only self-identify as having a medical illness, which many of them have, but also are at increased risk to develop prescription drug abuse. Why? Because one of the #1 risk factors for addiction is sheer access to drugs. If you live on a street where on the corner they're selling drugs, you have a higher risk of being a drug addict. Okay, I'm just going to briefly comment here on something I call the P paradigm. It has to do with provider incentives for ignoring prescription drug abuse. We as providers, at least certainly as physicians, are really, really incentivized to prescribe pills, perform procedures, and please patients. Pleasing patients is an even more relevant new phenomenon. We've got something called Press Ganey. And Press Ganey is a survey business that's now hired by hospitals to pass out surveys to patients to ask them about their satisfaction with their doctors. And one of the questions on many of these Press Ganey surveys is, did your doctor adequately address your pain? Hey, that's really important for doctors to get good grades on those surveys. They hear from their division chiefs, they hear from higher ups in their community. You've got to make sure that your patients are happy with your care. This is really problematic when you're wanting to engage a substance abusing patient who is in denial about their prescription drug abuse. You better have a lot of time to do that, and time is one thing that you don't have if you're trying to bill. Interestingly, a study came out in 2012 looking at geographic variation in opioid prescribing. So basically, they looked across the country and they said, where are most of these opioid prescriptions? Where is this happening in the United States? The highest rates, they were found in Appalachia. No surprise, you guys, I'm sure, heard about the terrible issues in West Virginia, and also the southern and western states. And they said, well, what are the correlates? You know, why are we seeing opioid prescribing being higher in certain regions? Is that where people are having more injuries, more need for analgesia? And what they found was that it was not reflective of differences in the prevalence of injuries, surgeries, or conditions requiring analgesics. The biggest predictor was, very simply, the number of available physicians in that region. The second number one predictor, socioeconomic status. Where poor people lived, there were more opioids being prescribed.